There have been studies, though, that have shown that adding growth hormone may enhance ovarian stimulation response, again, especially in poor responders. And this was a study that came out in Reproduction and Fertility, specifically looking at the effect of growth hormone co treatment in women who are 40 or older. Welcome to my fertility podcast, Superhumans, the show that brings you expert insights, personal stories, and the latest in fertility care all in one place.
Whether you're starting your fertility journey, navigating challenges, or just exploring your options, we're here to empower you with knowledge, support, and hope.
Join us as we dive deep into topics that matter most, from IVF and fertility treatments to mental health and wellness.
I'm Dr. Mavis Garcia.
And I'm Dr. Wise. We're two of the fertility specialists at Markham Fertility Centre in Markham, Ontario, Canada. Think of us as your sisters in all things fertility. Let's demystify the world of fertility together.
Happy Tuesday, Superhumans. Today, we're diving into a topic that is often surrounded not only by questions, but a lot of controversy. And I'm talking about add-on treatments to IVF.
Exactly. I mean, IVF is already such a huge investment, financially, emotionally, time-wise. One of the most common questions I think that we get is, how can I maximize my outcome?
It's a fair question, and it's a question that as physicians, as fertility specialists, we want to answer as well. How to maximize IVF outcomes? A lot of that has to do with other things that we have covered in the podcast, like lifestyle and supplements and taking your medications on time and making sure you're taking care of your health. Particularly today, we're going to be talking about add-on treatments that potentially can improve the chances of a live birth. Simply put, these additional interventions, medications, treatments can be used alongside your standard IVF protocol to potentially improve the outcomes. In this episode, we're going to be focusing specifically on treatments that are aimed at maximizing egg quality and subsequent embryo quality.
Yes. And just a note, this is by no means an exhaustive list. When I started researching this topic, the list absolutely ballooned. So we're going to be covering the most common adjuvant treatments or add-on treatments that we might be seeing on social media or that patients are asking us about frequently. But again, there's still many others that are out there, and I'm sure there's going to be many more that are going to come down the pipeline. Also, just to further clarify, on today's episode, we're not going to be covering treatments that are aimed at improving outcomes for embryo transfer. So let's say for people who have recurrent implantation failure. That's a huge topic in and of itself, and we promise that'll come up in a future episode. Now, a quick disclaimer before we get into things. These treatments are controversial, meaning the evidence is not 100% set to say that these things are necessary. And so we just want to be super clear that even if you are seeing a fertility specialist and they have not brought up some of these things, that's okay. The evidence is often mixed and can be difficult to navigate. But at the same time, we know that patients are hearing about these things and learning about these things. So we wanted to present the evidence to all of you so that you guys can take the information and speak to your doctors about it.
Let's start with one of the most common supplements, coenzyme Q10 or CoQ10. It's also known as ubiquinone or ubiquinol, and it is a naturally occurring antioxidant produced by the body.
CoQ10 plays a crucial role in several important biological functions. It participates in the mitochondrial electron transport chain, which aids in the production of ATP, the primary energy source for cells, as I'm sure we all remember from high school biology class. It also acts as an antioxidant, protecting cells against oxidative stress and helping maintain cellular membrane integrity.
Now, there's been some promising research here. For example, a randomized control study found that CoQ10 pretreatment led to lower gonadotropin requirements and higher estrogen levels in young women with poor ovarian reserve. Women who received CoQ10 pretreatment had more high-quality embryos. This study was published in 2018 in the Journal of Reproductive Biology and Endocrinology.
Now, better response to embryos is good, but obviously the goal of fertility treatments is pregnancy. And so coenzyme Q10 supplementation has been shown to increase clinical pregnancy rates. In fact, there was a big meta analysis which combined information from 5 other randomized control trials that showed that coenzyme Q10 supplementation significantly increased clinical pregnancy rates in women undergoing IVF. In fact, the pregnancy rate for women who were taking CoQ10 was about 29%, versus women who are not on it, the pregnancy rate was about 14%. And this was a study that was published in 2020 in the Journal of Assisted Reproductive Genetics.
The recommended dose in the studies that we talked about before for CoQ10 is typically between 300 and 600 milligrams a day, starting approximately 3 months prior to starting your IVF treatment.
Coenzyme Q10 or CoQ10 supplementation has shown really promising results for improving IVF outcomes, particularly in women with lower ovarian response or diminished ovarian reserve. And the risks of taking it are relatively low. So this is something that, we will often recommend for most patients.
All right. So, good news about the CoQ10. Now, let's talk about another supplement like omega 3 fatty acids. Omega 3 fatty acids are essential polyunsaturated fats. The three main types are ALA, EPA, and DHA. ALA is found in plant sources like flax seeds and walnuts and chia seeds, and EPA and DHA are found primarily in cold water fish.
The effect or the benefit of omega 3s for improving embryo quality and egg quality is unfortunately less clear than it is for CoQ10. So let's go through the evidence. There was a study that showed that taking omega 3s can improve embryo quality. In fact, there was a cohort study of women who were going to do IVF with ICSI, and they found that increased dietary intake, specifically of ALA and DHA, in the 4 weeks leading up to their stimulation may have improved embryo morphology. This was a study published in 2017 in the Journal of Assisted Reproductive Genetics.
However, in contrast to that, there was a systematic review of 5 studies involving about 1,100 women that didn't find a significant link between omega 3 intake and higher clinical pregnancy rates. And this study was published in the Human Reproduction Journal in July of 2021.
When we look at the studies looking at the effects of omega 3s, there is so much variability in terms of which omega 3s people were taking at what dose and for how long, and whether it was coming from supplements or diets. And so that's why the studies and the evidence are really just not nearly as clear for omega 3s as it is for coenzyme Q10, for instance. That being said, sources that have shown a benefit have suggested aiming for about 600 milligrams of DHA and about 1,000 milligrams of EPA daily to help support embryo quality during an IVF cycle.
So now let's move on to DHEA. DHEA or dihydropendosterone is a hormone produced by the adrenal glands that peaks in our mid 20s and gradually declines with age. It has been studied in association with women with diminished ovarian reserve.
Now, it's important to note DHEA and DHA are very different.
Yes.
As we literally just talked about DHA as being one of the omega 3s, and now we're talking about DHEA. Just a heads up for those listeners who are paying attention.
And this is actually super important because DHA should continue when you are pregnant, and DHEA should not be taken when you're pregnant.
DHEA supplementation has been associated with better ovarian stimulation response during IVF, leading to a higher number of retrieved eggs. And some studies have shown that it can result in better embryo quality and higher numbers of top quality embryos. And again, this is coming from a study in 2010 that was published in the Journal of Human Reproduction.
There was also a systematic review and meta analysis that showed that DHA supplementation has been linked to higher clinical pregnancy rates and cumulative pregnancy rates in some studies. And this was published in the Journal of Assisted Reproduction in 2018.
The typical dosage that was used in the studies was about 75 milligrams of DHEA daily, and it was usually given as 25 milligrams 3 times per day. They would start it for several weeks before starting IVF. And again, it varied in the studies, whether it was 3, 4 weeks up to 3 months.
Now let's talk about androgel. Androgel is a topical testosterone treatment and it is related to DHEA. They're both androgens, so they act similarly. And as a matter of fact, sometimes we're picking between one or the other, and there have been some studies comparing one versus the other. So let's talk about the evidence for androgel specifically.
With androgel pretreatment, it's been shown to improve ovarian response. So, again, getting a higher antral follicle count and better response, meaning more eggs to controlled ovarian stimulation. This was a study that was published in 2014 where they looked at ovarian features after 2 weeks, 3 weeks, and 4 weeks of transdermal testosterone gel treatment and their associated effects on IVF in poor responders. There was another study by Kim et al. In this study by Kim et al., they also showed an increased oocyte yield, meaning getting more eggs retrieved and more mature eggs in women who were pre-treated with testosterone gel and who were poor responders.
There was a randomized control study published in 2018 that showed that there was increased embryo quality in patients that were pretreated with testosterone gel prior to starting IVF. So these patients had improved embryo quality and higher number of good quality embryos available for transfer.
And the study that I mentioned previously by Kim et al. Even took it a step further and showed improved pregnancy rates, both clinical pregnancy rates and live birth rates in women who are pre-treated with testosterone gel. Now, this is a big deal because in the world of fertility, there's not many studies that are necessarily looking at live birth rates because it can be very, very difficult to have that information. So, this is a really powerful and useful study. From these studies, the best we can tell is that the optimal duration of testosterone gel is probably about 3 to 4 weeks before starting IVF stimulation.
I mentioned earlier on how both DHEA and androgel are similar. They are in the same family. They're both androgens, which begs the question, if they're similar, then which one is better and how do we choose? Well, there was a review published which looked at 28 studies that between all of them combined information on 3,000 women. Participants in the study were women with infertility of at least 1 year duration. And out of the 28 studies, 14 of them looked at the evidence for DHEA and 14 looked at the evidence for androgel. This review of studies showed that androgel probably improved the chances of successful pregnancy in women that had poor responders for IVF, and that DHEA compared to androgel has little to no effects on the chances of a successful pregnancy in women who are poor responders.
This is a big deal. This is very strong evidence and really powerful evidence to come out. And, for physicians, when a Cochrane review tells us something, I think we all listen.
Mhm.
These researchers took things a step further and they showed that both of these androgens, so both DHEA and testosterone gel, likely do not decrease a woman's chance of miscarriage. And it's also uncertain whether either of these treatments increase the chance of multiple pregnancy. But certainly, I think, this is very good, very powerful evidence that definitely has changed my practice. And I'm a much bigger supporter of testosterone gel than DHEA these days.
Yeah, I'm the same. 12 years ago when I started, I was doing more DHEA, but the new studies that have come up since that time have made me change my practice as well about the use of androgel. Absolutely. So now let's switch gears a little bit and talk about another add-on that I used quite a bit, and that would be growth hormone.
Mhm.
Growth hormone, also known as human growth hormone or somatotropin, is a laboratory produced version of the natural growth hormone, which is produced by pituitary glands. There are some side effects of synthetic growth hormone that I think we need to discuss. That would include things like joint and muscle pain, fluid retention, headaches, increased insulin resistance, and elevated cholesterol levels. When it's used long term, it can lead to more serious side effects. Generally speaking, in an IVF cycle, it would be used for about 10 to 12 days during the stimulation phase. So the rate of side effects during IVF is much less.
But it's also worth pointing out that everybody's method for using growth hormone or their protocol varies wildly. I have definitely seen some studies where patients are on it for several weeks, actually, even leading up to stimulation as well. And again, that makes the research, the literature even harder to compare apples to apples. There have been studies, though, that have shown that adding growth hormone may enhance ovarian stimulation response, again, especially in poor responders. And this was a study that came out in Reproduction and Fertility, specifically looking at the effect of growth hormone co treatment in women who are 40 or older. And this was published in 2023.
We've been talking a lot about patients that are poor responders because that is, as you might imagine, a challenging situation to overcome when we're trying to make multiple embryos. But growth hormones have also been studied in patients who are not poor responders. So they would be patients that you do get a lot of eggs, but you don't get a lot of good quality embryos, which is ultimately what leads to the pregnancies. So this study showed that you can actually get increased egg and embryo quality when you're treating patients who are not poor responders with growth hormones. And this study was published in 2021 in the Journal of Assisted Reproduction and Genetics.
Let's go back to the Cochrane reviews. And so there was a Cochrane review about growth hormone that was published in 2021. In it, they included 16 randomized control trials with 1,352 participants. Now, in normal responders who were taking extra growth hormone as an add on, the effect on live birth rate is very uncertain, they called it. Basically, there was not enough evidence to reach a conclusion regarding clinical pregnancy rates, number of women with at least one egg retrieved, or embryo transfer achieved, or the number of eggs retrieved in normal responders. And again, the evidence they called also very uncertain about the effect of growth hormone on live birth rate for poor responders based on 8 different trials. Now, they did find that growth hormone resulted in a slight increase in pregnancy rates in poor responders, but this was based on 11 trials where they felt that there was a low certainty of evidence. Basically, the challenge is that all of the studies looking at growth hormone had massive variation in terms of dosing, in terms of protocols, when they started it, when they stopped it. And so it's very, very challenging to compare these studies and sort of to put the information together to make final conclusions. So, again, really with growth hormone, the evidence is generally quite weak for its use as an add on in IVF, but that's because we just don't have great quality studies yet.
Something else that many patients ask about is the use of letrozole. Letrozole is an aromatase inhibitor which reduces serum estrogen levels, which can then influence ovarian stimulation outcomes. It's important to know that letrozole is an off label use of this medication for fertility treatments. For poor responders, letrozole co-treatment, which means letrozole during a stimulation cycle, has been shown to have a significant increase in live birth rates by about 7% and a reduction in gonadotropin consumption without decreasing the number of retrieved eggs. This would suggest that letrozole can enhance ovarian response and potentially improve clinical outcomes in patients who are poor responders. And this was published in a study of reproductive biomedicine online in 2022.
What about normal responders? The addition of letrozole has been associated with an increase in the number of retrieved oocytes by about 1 eggs per cycle. However, there's no significant effect on live birth rate, clinical pregnancy rate, or the risk of OHSS or ovarian hyperstimulation syndrome. This indicates that while letrozole may increase the number of eggs we get at retrieval, it does not necessarily translate to improved pregnancy outcomes in this population. And again, this is coming from that very same study.
So we talked about letrozole in low responders. We talked about letrozole in normal responders. In high responders, there is really very limited data on the use of letrozole, and whatever we have shows no significant impact on live birth rate or clinical pregnancy rate. Therefore, more research is needed in this particular group.
When we think about add on treatments in the world of IVF, often we're thinking about medications or specific vitamins or supplements. But it can also include things like treatments, for instance, acupuncture. Acupuncture is a topic that merits a whole episode on its own. I mean, when I started looking this up, I realized there's like a multitude of different ways to perform acupuncture, ways to think about it, frequency, timing, specific points that are used, whether there's electrical stimulation that's happening or not. So stay tuned for that. We should definitely write that one down as a podcast episode idea. But it is worth mentioning here. There was a systematic review and meta analysis by Shan et al. That found that acupuncture significantly improved clinical pregnancy rates by about 1.26 times, with, interestingly enough, notable benefits, especially in Asian populations, particularly when electrical acupuncture was used during controlled ovarian hyperstimulation or that stimulation part of the IVF procedure. This was a study that was published in 2017 in the Archives of Gynecology and Obstetrics.
Another meta analysis reported the effect of acupuncture on both clinical pregnancy rate and live birth rate. It showed that acupuncture significantly increased both clinical pregnancy rate and live birth rate compared to control groups. For example, patients who did acupuncture had 43.6% in clinical pregnancy rate versus patients who did not, that had a 33% in clinical pregnancy rate. And the live birth rate was 38% in patients who did acupuncture compared to 28% in patients who did not do acupuncture. And this study was published in the Archives of Gynecology and Obstetrics in 2024.
In 2018, there was a big study that came out that garnered a lot of attention because it was published in JAMA, which is a very well known, very well respected journal. And it was a randomized control trial where they looked at acupuncture versus sham acupuncture on live births for women who were undergoing IVF. And in this study by Smith et al., they found that there was actually no significant difference in live birth rates, regardless of whether people had acupuncture or not. And this study really changed, I think, a lot of people's minds and really got people talking about acupuncture because it was such a high impact journal.
So, in summary, looking at all of these studies, it seems that acupuncture may improve clinical pregnancy rate and live birth rates in certain populations and settings.
I would venture to say that it also really depends on your acupuncture provider as well, in terms of what protocols they're using too. So, if you are thinking about trying acupuncture as an add on treatment for IVF, make sure you're seeing somebody that has experience in fertility and that really has a good understanding of different protocols and different points that are used.
Yeah, absolutely. Like in everything else, experience matters. And speaking of experience, we are going to have a fertility acupuncture expert on the podcast to come and teach us about acupuncture in fertility and specifically what to look for when you're looking at incorporating that into your treatment cycles.
So, on today's episode, we've gone through a wide gamut of different add on treatments. And it's important to note that, not every add on is appropriate for every patient, and some could even be harmful. It's also important to weigh the cost of these treatments against their potential benefits.
And let's not forget the emotional toll. Patients should feel empowered to ask questions and make informed decisions without feeling pressure to try every add on available. Just because an add on is there, it doesn't mean that you have to do it.
And just because an influencer on social media talks about it or worked for them doesn't mean it's necessarily for you either.
The key is to focus on evidence based care and have open communication with your medical team. And to learn more about the topic of IVF, don't forget to check out episode 14, IVF Part 1. Let's talk about IVF. And episode 20, IVF Part 2, which talked about the risk associated with IVF.
And that's a wrap for today, superhumans.
If you're looking to connect, get social with us. Follow us on YouTube and Instagram at My Fertility Podcast or visit us online at myconfertility.com. And don't forget, follow, subscribe, and share your favorite episode.
Thanks for listening to My Fertility Podcast and for being a vital part of our community. We know you've got this.
We're signing off until next Tuesday.
If you found this episode of My Fertility Podcast helpful, please take a moment to head over to the review section and leave us your thoughts. Your reviews and comments are incredibly valuable to us and help guide future episodes. We also welcome you to direct your questions to info@myfertilitypodcast.com.
My Fertility Podcast is produced by Rabbit Media Inc. in conjunction with Dr. Garcia and Dr. Weiss.
Music from Mixkit, Life is a Dream by Michael Ramirez C.
My Fertility Podcast is not intended to replace any type or variation thereof professional medical, health, or legal advice, nor should the content be taken as medical advice. Please contact your primary healthcare professional regarding any medical questions you may have. The information presented in this podcast is based on the knowledge and understanding of the host at the time of recording. Medical knowledge is constantly evolving, and new research may change the understanding of health-related topics. While we strive to provide accurate and up-to-date information, we do not guarantee the completeness, accuracy, or timeliness of the content. The views expressed in this podcast by guests are not those of the host or the management. This podcast is not intended to impose any type of discrimination. My Fertility Podcast and its management are not responsible for any losses, damages, or liabilities that may arise from the use of this podcast.